You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 7th, 2018. This week I'm talking about troponin, radial excess, stroke care, rivaroxaban, and what is a good diet. So we'll start with high-sensitivity troponin assays. Diagnostic tests are supposed to help improve patient outcomes, but all diagnostic tests come with upsides and downsides. Detection of myocardial enzymes in the blood have been a cornerstone of diagnosing heart attacks. In the old days, any amount of troponin, or CPK-MB even before troponin, was abnormal, and thus it was easy. Finding it in the blood allowed a diagnosis of MI. The problem in the old days was sensitivity. That test could miss small MIs. Now, high-sensitivity troponin assays are super sensitive, and low levels of enzyme may not indicate a true MI. At the current time, the sensitivity is much better, but the problem has become specificity. So investigators in the UK set out to study in an RCT whether the introduction of a high-sensitivity cardiac troponin assay with a sex-specific 99th percentile diagnostic threshold would reduce outcomes, reduce future MI or cardiovascular death in patients who presented with suspected ACS, acute coronary syndrome. Now, the researchers used a stepped wedge design, which is a really cool technique, and I'll just take a second to explain it. Here's how it works. During the validation phase of 6 to 12 months, results from the high-sensitivity troponin were concealed from the attending clinician, and the contemporary cardiac troponin was used to guide care. Hospitals were randomly allocated to early, 5 hospitals, or late, 5 hospitals, implementation, in which the high-sensitivity assay and sex-specific 99th percentile diagnostic threshold was introduced immediately after that 6-month validation phase, or was deferred for the further 6 months. The primary endpoint was subsequent MI or CV death. Lancet published a pragmatic study of 48,000 patients done in 10 hospitals. The standard contemporary troponin test used levels above 50 nanograms per liter, whereas the high-sensitivity test used in this trial is based on the 99th percentile of cardiac troponin in the general populations, which equated to levels above 16 nanograms per liter for women and 34 nanograms per liter for men, as women have lower troponin concentrations than men. The research team reported that the high-sensitivity assay increased detection of myocardial injury, but only 1/3 of reclassified patients had a true diagnosis of MI, and outcomes, primary endpoint outcomes at 1 year did not differ with the use of the high-sensitivity troponin assay. About 17% of the 10,000 patients were reclassified as having MI or injury who were not identified with a contemporary assay. So the test did change care. Patients reclassified to MI had double the length of stay, while the length of stay was halved in those with negative tests. Now, the authors expressed surprise over these results. In the paper, they cited previous observational studies which suggested MI is underdiagnosed with contemporary assays, and that misdiagnosis of MIs are associated with excess mortality, and therefore they figured a better assay, especially one that reclassifies this many patients and led to more care, would improve outcomes. Since it did not improve outcomes, they questioned whether the universal definition of MI diagnostic threshold should be used on the 99th percentile derived from a normal reference population. And I'd say, alas, that recommendation was based on expert consensus and observational studies. The authors suggest it's probably better to develop strategies to help cardiologists identify the correct patients for treatment, which is going to be unlikely to be based on a simple statistical threshold from a reference population. So if you love clinical decision making, this is a great topic, and we no longer have the binary yes, MI is ruled in, or no, MI is ruled out. So making this test more sensitive did not improve outcomes for patients, and yet here's another example of the fragility of expert opinion and observational studies. While more sensitive assays have better negative predictive value, these new assays will require more from the clinician at the bedside. The clinician will need to use more skill and intuition to diagnose and treat patients with suspected heart disease. Finally, the last note on this is an important question pointed out in the accompanying editorial is whether or not these high-sensitivity assays can safely rule out MI by use of a baseline and 1-hour protocol. So the next topic is about radial access for PCI. Now, I think often about the value of care, that is, the cost versus the net benefits. Here, think of the typical concave utility function used in economics. You put cost on the x-axis and benefit on the y-axis. High-value care is on the steep part of the curve. You get lots of benefit or utility at not much cost. Low-value care, on the other hand, is on the flat of the curve. So the original Matrix trial pitted radial versus femoral access for patients with ACS, and it showed no difference at 30 days between the radial and femoral access groups regarding major adverse cardiac events, MACE, but did show significant reductions in major bleeding and all-cause mortality with the radial approach. The Matrix investigators presented 1-year results at ESC. The results looked even better for radial access. It had 11% relative risk reduction with a confidence interval of 0.8 to 1.00, so just touching 1.0, but still the point estimate 11% reduction with radial access. But again, they had 13% fewer net adverse events, and that met statistical significance. Cardiovascular mortality was 2.1% in the radial arm, 3.0 in the femoral access arm. So my comments here is that using radial access for PCI is a classic steep of the curve practice. It doesn't cost any extra, and it improves outcomes and reduces adverse events. The thing is, doctors have to take time to learn it. This was no big deal for trainees, but it was a big deal for lifelong learners. They had to switch techniques, learn a new approach, because it was clear that this was going to be better for patients. Then cardiology did what it has been known for and famous for. It generated RCT-level evidence, and the evidence looked positive for this new technique. Hey, I just realized this is a good news story. So listeners, please tweet. Mandrola is reporting good news. Next topic is stroke care. Now, when you study and report on stroke care from a data set that includes 6 years and about 50% of all U.S. hospitalizations from 22 different states, you deserve credit. Good on the researchers for doing this. The question they asked was whether 30-day readmissions among patients with stroke changed much between 2010 and 2015. And the answer was yes. After looking at more than 2 million patients, readmissions after stroke declined by about 3.3% per year on average. And as expected, readmissions were higher after patients with intracranial hemorrhage than it was for patients with acute ischemic stroke. Now, this study differs importantly from other studies that have used CMS data because CMS data only looks at those aged greater than 65, whereas this looked at a much broader population. But the problem with this study, and it's no knock on the researchers, is that I question the premise of the 30-day readmission as a metric. The authors say readmission reduction is linked to improved quality of care, a reduction of cost, and is desirable patient-centered outcome. So I'm not sure about number 1 and number 3 there. Yes, readmission reduction is linked to improved quality of care metrics, but I'm not convinced it is linked to better outcomes. For instance, after stroke, functionality and mortality are far more important measures than process measures like, say, adherence to statins. And don't even get me started on the limitations of the Sparkle trial. Also, is a 30-day readmission really a patient-centered outcome? I mean, what about 31-day readmissions or 3-month readmissions? Now, to be clear, I am all about improving care for patients who have serious diseases, but gosh, just as we should be careful about surrogate endpoints in clinical medicine, we should also be very cautious with surrogate endpoint studies taken from observational data sets. Now, my biggest beef with the proliferation of these quality measures is that they are inducing gaming of the system that occurs to make patients sicker on paper. I hate that because I always try to extract fear from patients by emphasizing the positives and downplaying the illness frame, because scaring patients with how sick they are worsens the power asymmetry already present in the caregiver-patient relationship. The next topic involves rivaroxaban. So European regulators have now approved low-dose rivaroxaban for a new indication. Remember the COMPASS trial that was published last year in the New England Journal of Medicine. It was an industry-sponsored RCT of 27,000 patients with established vascular disease, in which the investigators tested whether low-dose rivaroxaban alone or in combination with aspirin would be more effective for secondary prevention of events. Remember, these are patients with disease. The three study groups of COMPASS were rivaroxaban 2.5 twice a day plus aspirin, or rivaroxaban 5 twice a day alone, or the third group was aspirin alone. And for efficacy, rivaroxaban plus aspirin reduced the primary endpoint, which was a composite of CV death, stroke, or MI, by 1.3% in absolute terms, 4.1% versus 5.4% event rate. Rivaroxaban alone at 5 BID also reduced the primary endpoint, but the difference did not reach statistical significance. But for safety, rivaroxaban plus aspirin increased major bleeding by 1.2%, including a near doubling of bleeding requiring transfusion. Now, based on these findings, the European regulators approved rivaroxaban 2.5 BID plus aspirin at a low dose for this indication for secondary prevention. Now, this is notable because it is the first direct oral anticoagulant with an indication for use in atherosclerotic disease. Now, at the time COMPASS came out last year, I wrote about this trial, and it's hard for me to see how this regimen delivers a great deal of net benefit because the absolute risk reduction is small and it's counterbalanced by significant bleeding. What's more, this drug will likely be costly, and it adds another BID drug regimen, and that increases the pill burden and the work of being a patient. If you look at this gain at an individual level, I see it as a classic flat of the curve, low value regimen. In other words, minimal benefit and high cost. Final topic today is about diet. Now, patients always ask about the specifics of a heart-healthy diet, and I usually answer the same way. I say, okay, make it a good quality diet, and you know the basics. Well, you can leave it to Canadian researchers from the Pure Study Group to sort this out. In their latest presentation at ESC, they found a strong association of a generally good quality diet to lower death rates overall and lower cardiovascular events. Now, how did the Canadians define a good quality diet? They based it on the intake of 7 key foods: fruits, veggies, nuts, legumes, fish, dairy, and red meat unprocessed. Now, of note, 5 of these 7 foods are not controversial, and the 2 that are, dairy and red meat, are recommended in this quality diet in very small quantities. Say 3 servings of dairy and 1.5 servings of unprocessed red meat are what they think is high quality diet. So now they're not saying go eat a ton of meat or drink a bunch of dairy. So in this analysis of Pure, they broke down a diet quality score into quintiles from least healthy to most healthy. They then applied the score to multiple data sets and found consistent associations with A, lower death rates, and B, fewer major adverse cardiac events. Now, interestingly, cardiovascular mortality was not decreased, and the lead investigator, Dr. Mente, explained to me that this is because overall lower death rates were driven mostly by lower rates of death from cancer and other non-cardiac disease, which is exactly what you'd expect with a better quality diet. In other words, eating well doesn't just help reduce cardiac events, it helps prevent a lot of other health problems. So take a look at Sue Hughes' excellent news story on this. I also have an interview with Dr. Mente coming soon. Now, I know the diet debates will go on, but this is compelling data, and it reinforces my mastery of the obvious bias that the best health comes from moderation. Moderation in the diet, moderation in lots of things. One quick note before closing. If you like this podcast, and I hope you do, consider subscribing to it and giving us a good rating so that other people can find it as well. I'm grateful that you listened. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.